is Adil. My name is Adhil Razak. I am a fifth-year medical student, and today I will be giving you guys a session on dermatopathology, or your pathology lectures in dermatology. I'll be covering all the lectures by Dr. Abara pretty much, and I've tried to incorporate a little bit of clinical concepts here and there from your clinical lectures. I wanted to add more stuff, but I don't think our time would accommodate that. There are a couple very, very crucial clinical concepts from your clinical lectures that I'm not included in this, but I want to mention it right from the beginning because you are going to be tested on it on Sunday, including acne and the tinea fungal infections. Please go through them well because you're going to have questions on them. Other than that, I think I've covered almost all of your pathology lectures. All right, so let's get started. All right, so would anyone like to read the question? No issue, I'll read it. Okay, so we have a 21-year-old woman who returns to the physician's office because of an itchy rash that developed 2 hours after receiving an injection. So this morning she was diagnosed with an uncomplicated pyelonephritis, kidney infection, and the physician administered an IV of ceftriaxone and oral ciprofloxacin. There should be a photo of the rash. Oh, whoops. So I don't know. Okay, so yeah, it's there should be a photo. Is it in here? Yeah. Anyways, a spoiler alert, I guess that won't happen again. All right. So as you can see, the answer is C, awkward, and that is hyperpermeability of superficial dermal microvasculature. But can anyone explain to me what exactly happened here? So what is the issue with this patient? All right. So it's pretty much a case of urticaria or an allergic reaction, pretty much. So as you can see, this patient was given ceftriaxone and ciprofloxacin, but usually urticaria can happen with when a patient is administered penicillins or ceftriaxones, which is a part of cephalosporins. And this can cause urticaria, which is itchiness, pretty much, in a rash. And it's usually an IgE-mediated mast cell activation, or a type 1 hypersensitivity reaction. So, and what this comprises of is a release of histamine and vasodilation and pretty much hyperpermeability of the superficial dermal vasculature, which results in the tiny vessels in it becomes more permeable as well, releasing more inflammatory mediators such as histamine, for example, resulting in more itching. So to quickly go over it again, so the most important things you need to know about urticaria, as you can see, these are the pictures. It looks something like this, pretty much, or pretty much like this. And the most important thing is that it is mast cell degranulation, which improves the hyperpermeability of the dermal microvasculature, as I mentioned earlier. And pruritus pretty much gives it away, or itchiness pretty much gives it away, that this is what's happening with this patient. Although pruritus is obviously associated with other conditions, a patient who recently took penicillin or cephalosporin or something like that and suddenly starts itching, it's urticaria. So there's 3 types mainly, actually, pretty much 3 types. And then the 4th one is, I would consider it in a different category, honestly. So the 3 types are where the first one being mast cell dependent and IgE dependent, where both are involved, both mast cells and IgE. So this could be due to a pollen allergy or drugs, as I mentioned earlier, penicillin or cephalosporins like ceftriaxone, like venom or anti-venom even, or even a food allergy could come under this. So one of the options here is IgE-independent mast cell activation in subcutaneous tissue. So there's 2 things that doesn't add up with our case here. One thing is that a penicillin or a ceftriaxone allergy is IgE dependent, as you can see. So option D says IgE independent. Although it is mast cell dependent, and that adds up in here as well, mast cell activation. This is subcutaneous tissue. But in urticaria, in such a situation, subcutaneous tissue is not involved. The next type is mast cell dependent and IgE independent. In our previous example, mast cell was involved and IgE was also involved. In number 4, or option number 2, or type number 2, mast cell is involved and IgE is not involved. This usually is an allergic reaction due to contrast or opioids or other antibiotics or even Curare. And a third type would be where neither mast cell or IgE is involved. This could be due to aspirin. This is an example for aspirin where there's no mast cell or IgE independent. So if you get a case in your exam where a patient is having urticarial symptoms, itchiness, redness, etc., etc., and the patient has a history of taking aspirin, a painkiller, just before this started, if you have options saying mast cell dependent, IgE independent, mast cell dependent, IgE independent, and one that says neither, like neither mast cell nor IgE, that's your answer, because aspirin does not involve either. Angioedema could be caused by C1 esterase inhibitors, C1 inhibitor deficiency, or by taking ACE inhibitors. I think you guys are familiar with ACE inhibitors, which are a hypertension medication. Chronic use of ACE inhibitors and angioedema is one of the most important side effects that you need to keep in mind. That ACE inhibitors are not in the scope for today's lecture, at least, so I'm not going to go in deep into that. But angioedema does involve subcutaneous fat, which is discussed in option D. So option D is wrong. All right. So any questions so far? Okay. Next question. All right. So a 28-year-old woman is brought to the ER by her family due to acute left flank pain. The pain radiates to her groin and is associated with pink hematuria and urinary urgency. All of this is just fat in the question. Nothing in the history, has never experienced similar symptoms before, urinary symptom, presence of a stone, urethrovesical junction, given IV morphine sulfate for the pain relief. Since you know what topic we're on, this should kind of give you away what exactly we're talking about. 15 minutes later, she starts itching in her arms, legs, and back. Which of the following is the most likely mechanism causing this patient's reaction? Anyone? I don't know how many people are here now. Anyways, it's IgE independent mast cell degranulation. As you can see, this is a URL question, and a lot of people got this wrong. Most people got the wrong answer, picked the wrong answer. So if you got this right, good for you. Like you got the you're special, I guess, to some extent. So yeah, this patient took morphine and developed urticaria, which is diffuse itching around the arms, legs, and back, whatnot. So this is IgE independent mast cell degranulation, as discussed earlier. IgE independent, including opioids, which include morphine. All right, next question. So we have a 23-year-old woman who comes to the physician, I think. Oh, someone was answering in the chat. Sorry, I didn't see. Anyways, all right, a 23-year-old woman comes to the physician because of 5-month history of pruritus rash on cubital fossa of the upper extremities. She has no history of serious illness and takes no medications. A skin biopsy shows intraepidermal accumulation of edema, edematous fluid, and widening of intercellular spaces between the keratinocytes. Which of the following is the most likely diagnosis? The answer is C. Whoops, C, atopic dermatitis or eczematous dermatitis. Eczematous dermatitis is an umbrella term, honestly, and it consists of atopic dermatitis, irritant dermatitis, contact dermatitis, a lot of this stuff, but your lecture focuses on atopic dermatitis. So yeah, in this patient, you have a situation of atopic dermatitis. It's a young woman, presents as 5-month history of pruritic rash on the cubital fossa, which is a flexor surface. And usually dermatitis or atopic dermatitis happens in your flexor surfaces. So a skin biopsy showed intraepidermal accumulation of edema, edematous fluid, and widening of the intercellular spaces between the keratinocytes. This is describing a process called spongiosis. Let's just look more into it. This is an image of how it would look like. Honestly, this image looks more like irritant dermatitis, more scaly, dry type, honestly. Irritant dermatitis also looks a lot like this, which is more dry, I would say. So let's talk a little bit more about eczematous dermatitis. The important points being it's reddish, oozing, crusted lesions, pruritus, absolutely. and it usually affects the face or the flexor surfaces like your cubital fossa, as mentioned earlier. There are different subtypes under eczematous dermatitis, like allergic contact, atopic, drug-related, photoeczematous because of sun, primary irritant, such as using a specific product for like bleach or detergent or something like that could lead to eczematous dermatitis. If a patient presents with a similar presentation, but his history is that he started a new job at a lab or something, and he's working with a particular fluid, like I don't know, example fluid, and then he suddenly has this itchiness and rash in his body. What you can think of as eczematous dermatitis or allergic contact dermatitis. To do a quick overview on the pathophysiology, the antigens from the irritant come to the skin, and the dendritic Langerhans cells take up the antigen, and they take it to the lymph nodes, and it is processed by the CD4 T cells. Quick, very basic immunology stuff. So this is taken up by the effector memory cells, and memory cells now know, okay, this is a problem item. This particular antigen is a problem item. So when there's a re-exposure, the memory T cells act up. They go to the affected skin site and they adhere to the post-capillary venules and surrounding tissue. Pretty much they go out and go to the upper skin, and then they slip out of the tiny vessels that are involved, and they release cytokines and chemokines, which further attract more inflammatory cells like neutrophils, mast cells, etc., etc. So it pretty much causes the whole thing. So it all begins with dendritic Langerhans cells. And yeah, as I mentioned, it can be triggered by a touch of allergens, food, drugs, etc. And if there is a bacterial infection on top of this, so you must know that by this point, because of the whole inflammation, skin is now exposed to the open air and at risk of bacterial superinfection. So if there is bacterial superinfection, you call this impetigo. And impetigo is characterized by yellow crusting on top of it. Yeah, if a patient with impetigo has fever, it's a pretty bad sign. All right, there are no questions so far.
I have a question.
Yes.
So what's the basic difference between contact dermatitis and atopic dermatitis in general?
Okay. Atopic dermatitis, the thing is, contact dermatitis is more about the irritant itself. Like when the irritant is taken off, it pretty much goes away. But with atopic dermatitis, it is more of a chronic condition, I would say. Like it could happen and it could be there for a while, and it doesn't really entirely depend on the irritant itself. But contact dermatitis, if the patient is the irritant is taken away, it just goes away as well. Is that understood?
Thank you so much.
No worries. And yeah, like I said, atopic dermatitis, it's almost like autoimmune, I would say. All right, quickly going over how eczema is developed. All right, so let's start with A, which is dermal edema and perivascular inflammatory infiltrate. All right, at this point, there is edema being formed, it is getting swelled up, and the perivascular infiltrates are also happening. Inflammatory infiltrate is also happening. So it releases the cytokines and it swells up. The neutrophils release stuff and it swells up. Like, I'm not going to get into too much detail about it. I don't think you'll be asked in detail about the development anyways, just steps. And by B, it could be, the swelling could be classified into spongiosis. It pretty much becomes like a sponge, like it bubbles up. And there is microvesicles formed, right? Like right here, can I make it into a laser? Yes, as you can see, there's a microvesicles formed and it bubbles up even more. And by C, there is more scaling and parakeratosis and acanthosis. And parakeratosis is pretty much more layering of the keratin layers, and it's developed. Usually by stage C, the patient notices something and start taking medication for it. By stage B, I would say, and by stage C, it's getting really bad. And by D, there's hyperkeratosis, and there's a huge layer of keratin on top of it, so it's layered up. It's become dry and thick and scaly. So I would say irritant dermatitis would often go to this level. And by E, the lesion has become chronic, and even after treatment, you could have a scar at this point by E. Is this part clear? Yeah, and one more thing about atopic dermatitis, since you mentioned it, atopic dermatitis is, if you get a question of a little child, 9 out of 10 times it's atopic dermatitis. Just keep that in mind. All right, this is just a quick reference slide. The uppermost layer with where the keratin and the parakeratosis happens is the stratum corneum, and where the keratinocytes are stratum spinosum, and stratum basale are where the melanocytes are, or where the cells that produce stuff pretty much they are pretty much in the basal layer or the stratum basale. Right now, we're not going to talk about melanocytes, but over the course of this presentation, we're going to get there. All right, one more question, actually, on this topic, I would say. All right, just to read it quick. This is a 53-year-old woman who comes to the clinic due to a skin rash for the last 3 weeks, and she had a pruritic rash of worsening severity involving posterior thighs. Keep in mind, it's 3 weeks. The patient began an exercise program to lose weight, applying topical analgesic cream to her thighs and buttocks after her workouts. And history is unremarkable. She does not use tobacco, alcohol, drugs. And on physical examination, it is an erythematous reddish rash with blisters, ulcers, and weeping drainage. Like there's a little bit of drainage too in there. So it involves the posterior thighs and it is bilateral. Which of the findings will be most likely in this patient? The answer is E. Although we did discuss hyperkeratosis and acanthosis in the steps, the most characteristic presentation for a patient with eczema or atopic dermatitis is E, spongiosis. And it's pretty much it's staple for dermatitis. So without it, there could be absence of hyperkeratosis, there could be absence of acanthosis, dyskeratosis. All of these could be absent, but spongiosis is always there with atopic dermatitis or eczema or eczematous dermatitis as the umbrella itself. All right, next question. Yeah, so it's a 6-year-old boy. He presents for evaluation of bilateral skin rash, erythematous skin lesion on the flexor of the elbows and the knees. He has been scratching the area frequently, and he has had similar lesions intermittently for the past 2 years. So a photograph of the lesion is shown. Why do I keep missing the photos? So there's a different version with the photos. I'm so sorry. Anyways, a photograph of the lesion of the back is shown. There's a photo later on. But yeah, I think I gave away the answer again. Listen, I'll fix up. All right, this is my first validation. All right, so this patient's skin lesions are most likely associated with which of the following? I think you must have already noticed the answer because I pressed next by accident, trying to find the photo. But yeah, the answer is reversible decrease in FEV1 and FVC ratio. Do you know why? Can anyone online explain it? All right, the rationale behind that, this is the photo I attached. I think I accidentally replaced the photo with the previous one. Anyways, this is a very important concept, and I'm not sure if you're going to be tested on this concept in the exam, but this is very, very important concept, especially because someone mentioned atopic dermatitis and asked a question about what exactly makes atopic dermatitis different from the others. Atopic dermatitis is very, very often associated with other allergic conditions like asthma. And you've done CVP, so you know that reversible decrease in FEV1, FVC ratio is pretty much diagnostic for asthma. It's the reversibility test for asthma. So a patient with asthma also has a chance of having atopic allergic dermatitis and allergic rhinitis and allergic conditions or even food allergies. Like a patient with food allergies are at a higher risk of asthma and dermatitis. So that is the concept behind this question, and it is a very important concept for boards and even your exams. All right, next question. We have a 66-year-old woman who comes to the physician because of 1 week history of pruritic blister formation. And the physical exam shows multiple 1 to 3 centimeter bullae on the palms, soles, lower legs, and inguinal folds. This is crucial. Gentle rubbing of the skin does not result in slowing of the epidermis. Immunofluorescence studies show the perilesional skin biopsy and are most likely to show depositions of antibodies in which of the following areas? Would anyone like to answer?
Probably in the dermal papillae.
Why do you think so?
Because the rubbing does not slough off the epidermis. I think this could be bullous pemphigoid, because they are tensile bullae.
That's a good point. And do you know what the sign is called? The rubbing of the slowing of the epidermis?
Is it the Nikolsky sign?
Yep, it's a Nikolsky sign. But the answer for this question is B. The question was asking immunofluorescence studies asking perilesional skin biopsy are most likely to show a deposition of antibodies in which of the following areas? So the antibody deposition in bullous pemphigoid, your diagnosis was right, is at the dermo-epidermal junction. All right, so I did add a picture for this one, thank God. So yeah, this is what it looks like. So there are these bullae, they're like 1 to 3 centimeters long, big, and if you rub it, it does not slow, negative Nikolsky sign. And yeah, as you can see, it's a thick, bubbly layer with all kinds of mess going on in the histology. So this is pretty characteristic of the bullous pemphigoid. So this is the immuno image that was discussed in the question. As you can see, the darker layer here is the epidermis, and the lighter, relatively lighter layer here is the dermis, and the autoantibody deposition happens in between them, as you can see. The dermal papillae, it's two down. So they're asking where exactly is the antibodies deposited. So the exact location of it will be right in between the dermis and the epidermis. Yeah. So as you can see, it's right in between the layers. It's a thin line delineating the edges of the dermis and the epidermis. All right. Bullous pemphigoid and pemphigus vulgaris. They're both very confusing. Honestly, it was confusing for me. If it's not confusing for you, good for you. Like honestly, but back then when I was studying MSI, this gave me a hard time to differentiate between them. But there are a few things that you can look for in the question to tell apart between them. So pemphigus vulgaris. Actually, let's focus on bullous pemphigoid since we already did a question on it. Bullous pemphigoid, you usually see it on a patient over the age of 60. So this patient is 66 years old. So it is a patient over the age of 60. So it's an elderly patient, but a relatively younger patient. If you see a patient who are in their 50s or 40s, and you see the whole bullae, the typical presentation, palm, soles, pleuritic, blister formation, blah, 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 and it all sounds pretty much the same, but the patient is younger, that means it is pemphigus vulgaris. They're both chronic conditions. They're both relapsing. They both come and go. They're both autoimmune. And one thing though, pemphigus vulgaris is painful. It's way more painful. And bullous pemphigoid, older people, and it is the more characteristic part about it is the itchiness. Pemphigus vulgaris is more painful. Very, very important distinction point between them. Pemphigus vulgaris, almost every question you're going to get on it, they will most likely mention a mucosal involvement. Mucosal involvement means something near the mouth area, something in the GI systems, like somewhere in the mucosa, there's something going on, usually the mouth. So that kind of gives away pemphigus vulgaris as well. And they were saying the bullae itself, for pemphigus vulgaris, it's flaccid and it is Nikolsky positive. So if you rub it, it's going to rupture. But bullous pemphigoid, it is Nikolsky negative, as our colleague mentioned here, and it is a tense bullae. Like in the histo image, you can see that it's a thick layer on top of it. So rubbing it is not going to break it. Autoantibodies. So this can also be confusing. So, but autoantibodies for pemphigus vulgaris is desmoglein 1 and 3. So the autoantibodies or the antibodies act against desmosomes themselves, directly to the desmosomes. But bullous pemphigoid, the antibodies are against hemidesmosomes. Bullous pemphigoid antigen BPAG1 and BPAG2. These are from your lecture. So yeah, these are the antigens called. These are what the antigens called, BPAG1 and BPAG2. It's easy to remember. BP, bullous pemphigoid, antigen 1, bullous pemphigoid, antigen 2. Pretty straightforward. In the histology, you see a row of tombstone in pemphigus vulgaris. We'll look into the histology in a second. You see subdermal clefting in bullous pemphigoid. As you can see, there's like cleft formation. Just like a lot of the histology, it goes over my head, to be honest. But it's just something you can remember from. But most of your questions are, for at least these conditions, are going to come about either the antibodies or the clinical presentation itself. So for the direct immunofluorescence, bullous pemphigoid, right here, you see IgG and C3. Like the complement C3 is also deposited right here. But for pemphigus vulgaris, it is only IgG. Treatment is similar for both of them. It's systemic glucocorticoids or NSAID, non-steroidal immunomodulators. But the bullous pemphigoid, they could also use topical glucocorticoids, something to apply on the skin. But pemphigus vulgaris being more serious, you highly rely on systemic glucocorticoids. So one weird way that I remember how to remember the difference between how to remember the antigens involved is by, all right, so look. So for pemphigus vulgaris, the condition is more serious. It's painful. It is Nikolsky positive. It can rupture, and it has mucosa involvement. It is a more serious variant of bullous pemphigoid. And bullous pemphigoid is kind of like the half-assed version of pemphigus vulgaris. At least this is how I remember. I don't know if it's going to help you. So for the half-assed version, it is pretty much, so pemphigus vulgaris, the effect is on the desmosomes. And for the half-assed version, the effect is on the hemidesmosomes, half of desmosomes. So for the half-assed version, the issue is happening in the hemidesmosomes. I hope that helps. All right, next question. 54-year-old woman, painful blisters under the arm, appeared 3 days ago. She had 2-month history of intermittent painful lesions in the mouth. Examination of mouth shows several erosions on the buccal mucosa and lips. Examination of the trunk shows flaccid blisters with 2 centimeter diameter. Skin biopsy shows detachment of the keratinocytes within the stratum spinosum. The patient's condition is most likely caused by antibodies directed against which component? What do you guys think this is? Yep, it is pemphigus vulgaris. But which one of these? Where are the antibodies in this one? Yep, it is desmosomes, and the involved antibodies are IgG. So here's an image. So as you can see, you can clearly see what they mean by tombstone, a row of tombstone in the histology. So these look like tiny tombstones. Pathologists are very creative in how they name stuff. Like, I don't even know. How do you look at this? And I mean, this isn't even far-fetched. Like, some of them are like just so absurd. Anyways, you can see the mucosa involvement. Right here, you see it's red and there is no blister because someone rubbed on it and the top layer got off. So it's an open blister now, increasing risk for infection in these patients. And as you can see, it's a 54-year-old woman. She's younger than 60. So another giveaway for pemphigus vulgaris. All right, it's a similar image. I don't think you can really tell much unless in the question they mention, okay, they detect IgG only. If they detect IgG only, it is pemphigus vulgaris. If they detect IgG and C3, it is both. All right, next question, unless anyone has any questions so far. All right, cool. Right. So we have a 68-year-old man who comes to the physician because of a 2-day history of a rash across his trunk and extremities. For the past 3 months, he has persistent pruritus in these areas. His grandson, who spent the weekends with him, recently had impetigo. He has hypertension, hyperlipidemia, osteoarthritis. 5 months ago, he was treated for gout. Current medications include captopril, thiazides, statins, allopurinol, ibuprofen. His vitals are normal. There are diffuse vesicles and tense blisters involving the chest, flexors, shoulders. Rubbing of the skin on the chest does not produce blisters. And the oral examination shows no abnormalities. This patient's condition is most likely associated with which of the following? This should be very obvious by now. This is C. Yes. The answer to this one is C. Why do you think it's C? I think my system's glitching. Anyways, can't open the chat. Who can tell me why is it C? Yes, it is bullous pemphigoid. Because of the IgG and C3 deposition and negative Nikolsky sign. Negative Nikolsky sign, so it does not produce, rubbing the skin on the chest does not produce blisters, which is negative Nikolsky sign, and also the patient 68 years old. Another giveaway for bullous pemphigoid. And yeah, older patient, tense blisters, and the skin does not produce blisters, and all of this adds up to bullous pemphigoid. So IgG and C3 along the base membrane of the epidermis in the immunofluorescence studies. Is that clear with everyone? Amazing. Let's go. Next question. All right. Now we have a 24-year-old woman who's younger, and she's here for a severely pruritic skin rash. And physical examination shows a symmetric rash, both sides, over the knees, the elbows, with tense grouped vesicles with severe excoriation marks. Excoriation marks pretty much mean that they are, itching marks. There are microabscesses in the papillary dermis, and you can see that on light microscopy. Immunofluorescence shows deposition of IgA. This is very, very giveaway of what the condition is at the tip of the dermal papillae. All right. So yes, someone got the diagnosis right. It is dermatitis herpetiformis. But which one of these is the answer? They're asking what condition the skin finding is associated with. Yes, it is D. Can someone tell me why it is D? Like, what is glide-independent hypersensitivity? I'm not sure if you know it already. I don't know if the doctor has mentioned it to you. Yeah, gluten allergy, close enough. It's celiac disease. Glide-independent hypersensitivity is celiac disease, and those patients cannot take gluten. And celiac disease is very, very highly associated with dermatitis herpetiformis. It's pretty much a giveaway sign of it. So on the right, you can see an image of what that looks like. And yeah, to discuss a little more about it, here we have the histological image and the immunofluorescence of it. So you see clusters of neutrophils on the tip of the dermal papillae. So as you can see, you can see the layer of epidermis in here, and what's below it is the dermis, and there is a cluster of neutrophils. Like you see that this part is like darker with like tiny dots on it. Those tiny dots are neutrophils. And the granular IgA deposition. So in this patient, like all these immunohistochemical images look the same, except if they tell you what exactly is being highlighted here. If it's IgA being highlighted, that's pretty much dermatitis herpetiformis. And the patient has, a patient could have a signs of, in the question, they could talk like, oh, okay, this patient has diarrhea, they have a stomach pain, things like that. And they tell you, okay, they also have a skin rash. They might not tell you IgA, they might not tell you give you any of these details. They just say, okay, patient with tummy ache, blah, 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 diarrhea, comes up with a skin rash on their elbows, knees, wherever. And they ask you the question, the answer is dermatitis herpetiformis. Is that clear for everyone? All right. Nice. All right. Next question. Are we going too fast? Is the pace good? Is it too slow? Amazing. All right. So right now we have a 14-month-old girl. She is brought to the clinic by her patients due to sores on her feet. She's 14 months old. It's an infant. So she took her first steps 3 months ago. She had blisters involving the soles of her feet, that subsequently break down and started healing slowly. This patient had a failure to thrive. The patient is, low in weight, low in height. That just means failure to thrive for her age. And the patient has frequent oral ulcerations, but otherwise she's been healthy and has developed normal development milestones. Examination shows small bullae at faint erythema with no scarring. Biopsy taken on the margin of the blister shows intraepidermal cleavage plane. So pretty much like the epidermis like falling apart. And which of the following most likely contributes to pathogenesis of this condition? All right, so someone said D. Why do you think it's D? Okay, but unfortunately it is B. The answer is B because of impaired keratin filament assembly. And yeah, this is the diagnosis. Can someone break down or like tell me what EB stands for? It is epidermolysis bullosa. It's epidermolysis bullosa. So let's talk a little bit about this condition. It is, you see a patient with, these symptoms, pretty much bullae, erosion, blisters, oral ulcerations, like a lot of this, and the patient is a young child, like a 14-month-old girl, which is like 2 years old to a little over 2 years. Oh, I'm tripping. Okay, a little over a year old, 14-month-old child, and a presentation like this, 9 out of 10 times it's going to be EB with the skin erosed off, as you can see in this image. So what exactly is EB? It is an inherited condition, and the mutations involve intraepidermal and dermoepidermal adhesion complexes. So whatever connections are between the epidermis itself and between the epidermis and the dermis they're all falling apart because of the mutations in EB. The most characteristic signs you can see in these patients are it starts in infancy, in childhood. There are bullae, erosions, ulcers, and they are Nikolsky positive, lesions triggered by friction or minor trauma. And the histopathology, you see intraepidermal cleavage. So the pathophysiology, that has to do with the keratin proteins. That's what the question was asking. Impaired keratin filament assembly. So it has mutations in the keratin proteins, and there is a defective assembly in the keratin filaments, and keratin kind of keeps things together. So when there's a defect in the assembly of these keratin filaments, the basal layer is also disrupted. The basal layer of the keratinocytes are also disrupted. So overall, the epithelial tissue becomes very fragile. So the thing just cleaves off, and it can easily, when you rub it, it can easily fall apart. Is this the one that leads to squamous cell carcinoma? No, this is not the one that leads to squamous cell carcinoma. This is a inherited disorder that just leads to bullae, and it just it's an ugly condition, honestly. Like if you've seen more pictures of patients with EB, it's very sad, especially because it happens to little children. But alhamdulillah, as far as I know, it does not lead to squamous cell carcinoma. I hope not. I hope it doesn't. Yeah, but newborns, it's hard for newborns to survive this. So your lecture has 3 types discusses this. Simplex, which affects the basal layer directly, and it encodes keratin 14 and 5. So the way you can remember this is that this has the simplest mutation, which is keratin 14 or 5. So simplex has the simplest gene mutation, which is keratin 14 or 5. For junctional type, I don't know how I can make this easy to remember. Like I tried to come up with something, but I don't know. Maybe you can think that, okay, A6 beta 4 integrin, unless you're really, really good at the histology of skin, and then you can remember that these are junctional proteins. So A6 beta 4 integrin is mutated in the junctional type, and And this happens in otherwise normal histologically looking skin at the level of the lamina lucida. And these proteins, the alpha 6 beta 4 integrin, alpha 6 beta 4 integrin, it is a transmembrane protein, which means that it's a protein that, if this is a membrane, it goes through the entire thing. And it interacts with type 4 collagen superstructures called containing of laminins. So yeah, but the third one, and possibly the worst one, it affects the lamina densa. And I guess you can remember this by thinking that lamina densa sounds, dense, serious. So dystrophic is the worst one. So maybe make that connection. And the mutation is in COL7A1. In your exam, you're most likely going to be asked about either simplex or dystrophic anyway, because simplex is the most common one, dystrophic is the worst one. This one is kind of right in between. So yeah, and there's a way to remember this. I'll show you guys in a second. Yeah, so this is the image, more images. So the hands right here are of a much older patient, so it's not a little child. But the image on the right is of a younger patient. As you can see, it's an ugly condition. So it forms these blisters. It can lead to bleeding and ulcers. It's pretty bad. All right, so this right here, interestingly enough, I saw this. I was going through Instagram Reels last night actually, and I saw this kid. He must be like 14, 15, and he has EB dystrophic type. Let's pretend his name is Cole. His name is not Cole, but let's pretend his name is Cole. Why? Because the dystrophic type, the mutation is on COL7A1 mutation. And this kid right here, he has the dystrophic type mutation. He must be like 14, 15, something like that. And his Instagram account is about, as you can see images. He posts videos. And his Instagram account is about his fitness journey as someone with EB. And he talks about how he eats so much food in a day, but at the same time, it leads to no weight gain for this patient because EB is severely associated with malnutrition. Like even if they grow up, they're going to be malnourished. If they survive through the childhood stage, they're going to be malnourished. This kid, as far as I know, he goes to the gym regularly. As you can see, I put an image of him working out. Even he covers his skin up for his exercises. But as you can see, he's covered in these blisters and redness. But he's doing his best, and a lot of people are much stronger than we are. That's all I would say. So yeah, I hope this little story. I put the ad of this. If you're interested in knowing more about this kid, I put the ad in the picture and also in the notes if you want to check him out. All right, everything good so far? Anyone has any questions? Amazing. Someone, yeah, you won't forget Cole now. All right, it's COL7A1. I guess just pretend he's like 17 or 7, I guess. Anyways, next question. So this is an otherwise healthy 28-year-old woman who comes to the physician because of 14-day history of painful red nodules on her legs. Red nodules on her legs. She has malaise, mild joint pain. She reports that the nodules were initially smaller and distant, but some have fused together over the past 3-4 days and now appear like bruises. There is no, there is no preceding history of fever, trauma, or insect bites. Her vital signs are within normal limits. A photograph of the tender lesion is shown below. I added a picture for this one. And the remainder of the examination shows no abnormalities. The most important thing is that the patient has a high ESR level, erythrocyte sedimentation rate level, which is 30. So what does high ESR indicate? Skipping a couple steps. Deep wedge biopsy for panniculitis. Yes, it is panniculitis, but you saw that the answer is chest X-ray, erythema nodosum, part of panniculitis. Why do you think it's chest X-ray? I don't know if you're going to get questions like this in the exam, but it's an important point. Scoliosis is a good shout. Fibrosis is also a good shout. But the most important thing, it could be anything. Yeah, someone's a TB, I would say that is the most important answer for that. Because often at times, most of the time, erythema nodosum happens with an infection. So It is a type of panniculitis, which is infection of the fat layer. So it is associated with infections such as TB, as someone mentioned, histoplasmosis, leprosy, beta hemolytic strep infection could also lead to this. Sarcoidosis, which is fibrosis, and IBD. IBD, you guys haven't learned IBDs yet, next semester. Even malignancies could come with erythema nodosum, but often there is no cause, it just happens. Drugs can also cause it. Sulfonamides, OCPs can also cause erythema nodosum. Briefly about the histology. So in early lesions, there is widening of the connective septa because of the edema, and there is an exudation of fibrin and an infiltration of neutrophils. So I don't think this image has it clearly, but what you can see is that the white stuff is fat. Like whatever looks like this, 9 out of 10 times it's fat. On other times it's just empty space. So in the question vignette, if they describe neutrophil infiltration and fibrin exudation, it is an early EN, erythema nodosum infection. But if they say lymphocytes, histiocytes, multinucleated giant cells, it is a later presentation. This little example applies for pretty much almost every condition there is. Like in the beginning, it's always neutrophils and fibrin, things like that. Later on, when the disease gets worse, you see lymphocytes, histiocytes, and multinucleated giant cells coming in. So this is kind of like a general infection ABC. First neutrophils, and then lymphocytes, histiocytes, multinucleated giant cells. So yeah, one thing to know is that vasculitis is not seen in erythema nodosum. But if the patient presents with erythema nodosum and they have symptoms of vasculitis, it just means that it is a different name. It is erythema induratum. So if a question asks you, gives you a vignette similar to erythema nodosum, patient has an infection, blah, 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 and it's, nodules, it's red nodules that suddenly popped up in this patient. They described the histology. And they also mentioned symptoms of vasculitis. The patient has, difficult leg pain or headaches, symptoms of vasculitis. That means it is erythema induratum. If they give you options, erythema nodosum, erythema induratum, or anything else, pick erythema induratum. Look out for symptoms of vasculitis in questions that talk about erythema nodosum, just so you don't mix those up. All right. So far, is everything clear? Or anyone have any questions? Keep doing that. Hopefully by halfway through the session, I stop doing that. Anyways, so we have a 32-year-old woman. She has a recurrent vesicular genital rash, and she comes to the physician because of a 3-day history of painful, pruritic, itchy rash, begins on the extremities and has spread to her trunk. She's on acyclovir, and her temperature is 38 degrees. She has a fever, and her skin shows several reddish purple papules and macules. You guys know what papules and macules are. Macules are the flat ones, small flat ones. Papules are the small raised ones. If it's smaller and flat, macules, small and raised papules. It has a dusky center with a lighter ring around it. It looks like it's a bullseye lesion. It's almost a bullseye lesion around them. So which of the following is the most likely diagnosis? I already showed it somehow. So yeah, the answer is erythema multiforme. And you can see the image right here. It's very characteristic. Like if you see this image, it is erythema multiforme. And yeah, there's a dusky center. There's a lighter ring around it. And yeah, these are reddish purple and papules and macules. But can someone tell me why is she taking acyclovir? Why is she having vesicular genital rash? And why exactly does she have erythema multiforme? Yes, correct. It is because she has a herpes infection, viral herpes infection. So erythema multiforme is very, very highly associated with herpes, which is a genital infection. And she takes acyclovir. Acyclovir is the go-to treatment for herpes. And acyclovir does not cause this. I mean, as far as I know. Don't quote me on that. I don't want to give any reassurance on that. But in this case, erythema multiforme is caused by the herpes infection itself. All right. So yeah. This is another image. You can see this. This image is a little less characteristic, but at the same time, you can see that there is a reddish center. It's a flat image. There's a reddish center surrounded by a lighter outer ring. And it is caused by infections such as herpes simplex, mycoplasma infections, histoplasmosis, coccoidomycosis, typhoid, leprosy, and other infections. In your exam, in your MSI exam, you're probably gonna have a vignette of herpes simplex rather than the rest. But just keep this in mind in case they pull a fast one on you. Drugs can also cause it, like sulfonamides, penicillin. Once again, fun fact: I'm allergic to penicillin, so I'm never taking penicillin. But as you can see, it can cause a whole bunch of stuff. But yeah, it's a pretty useful drug, I would say. But but barbiturates, salicylates, hydantoins, antimalarials can also cause erythema multiforme. So yeah, it is associated with drugs, but I'm just not sure about acyclovir. I don't think it is. It could also be associated with malignant disease. Malignant conditions come up with a lot of skin manifestations, like left and right, you'll find a bunch of stuff. Later on in this presentation, I'm going to be discussing one particular skin condition that is associated with one particular malignancy. If you know it, if something popped up in your mind, that means you have that concept clear, which is good. So it could also be associated with collagen vascular diseases such as lupus. Lupus can also pop up a bunch of skin lesions. You guys have lupus and dermatomyositis. So lupus and dermatomyositis could also have very characteristic lesions, and erythema multiforme is not specific for these conditions, but it could happen. You could see them in these conditions. It is a type 4 hypersensitivity reaction. They cause these target lesions, dark in the center, white outside, very commonly associated with herpes. There is superficial perivascular lymphocytic infiltration associated with dermal-epidermal junction. This particular type of presentation in the histology is called interface dermatitis, where there's lymphocytic infiltration between the epidermis and the dermis. Let's quickly discuss it. As you can see in this image right here, there are a bunch of black dots, dark dots between the dermis and the epidermis. Now, those are lymphocytes, and this is called interface dermatitis. What exactly is interface dermatitis? Interface dermatitis, once again, it's when the lymphocytes are between those two layers, and it could result in hyperpigmentation because it could affect the melanophage cells, which absorb melanin, and it makes them not work anymore. And this happens due to this lymphocyte accumulation between these layers ends up damaging the basal layer of the epidermis. So that ends up, affecting the melanophages and not the melanocytes. So there could be hyperpigmentation in these patients. And another condition where interface dermatitis happens is lichen planus, which we'll be discussing soon enough. All right. So we have a 56-year-old woman who comes to the ER because of a 3-day history of malaise, dysuria, and blurred vision. Where is she? Yeah, and painful itchy rash. The rash began on her chest and face and spread to her limbs and soles. 1 week ago, she was diagnosed with trigeminal neuralgia, and she was started on a new medicine. She appears ill. Her temperature is 38. She has a fever. Her pulse is 110. Physical examination shows conjunctival infection and ulceration on the tongue and palate. There is no lymphadenopathy. There is examination of the skin showed annular erythematous macules, bullae, and desquamation of the palms and soles. There's a whole bunch of mess going on. And epidermis separates when the skin is lightly stroked. So this is Nikolsky positive. Nikolsky positive conditions are pretty bad. So which of the following is the most likely diagnosis? All right, we have the answer. Yeah, it is right. It is right. Don't second guess. It is Stevens-Johnson syndrome. And yeah, when it is more than 30% of the body or the 30% of the skin that is affected, it is toxic epidermal necrolysis. So what exactly is Stevens-Johnson syndrome? Stevens-Johnson syndrome is often caused by drugs, usually drugs used for neurological conditions, such as for trigeminal neuralgia. I don't know if you took this in neuro. For trigeminal neuralgia, the treatment is carbamazepine, and that's what the medication was, and which is what causes Stevens-Johnson syndrome. It is very rare. It's not like it happens all the time. It is a rare condition. And the drugs that cause this are usually neurological medication, like I mentioned, including carbamazepine, phenytoin, lamotrigine, valproate, pretty much the epileptic patients. The vignette could describe a patient with epilepsy, and they might not even mention that they are taking this medication. It's just, okay, patient with epilepsy showed up with macules, bullae, desquamation of palms and soles. The examiner expects you to assume that this patient is taking one of these medications. So what's wrong with this patient might be Stevens-Johnson syndrome, and if it's covering more than 30% of the body, it is worse manifestation called toxic epidermal necrolysis. The patient could also have fever and even flu-like symptoms like chill, myalgia, and those could also be accompanied by this condition. They could also have mucositis, conjunctivitis, corneal ulceration, and positive Nikolsky sign, and so on and so forth. The treatment for this condition is usually you just give fluids, you manage the wounds, and first thing, you stop the medication. You stop the medication that could have possibly caused this. Just to go over them a little bit more. Redness, blisters, and erosions on the lips, inside of the mouth. As you can see here, redness, irritation. There's the eyes, the mucosal surfaces. There's blistering, peeling skin, positive Mikulski sign. It starts from the face, the trunk, and then spreads outward. So it starts from the center. And could be early stage rash, could be flat and slightly raised, and later on it starts blistering. All right, next question. Are everyone clear about Stevens-Johnson syndrome and TEN? All right. So we have a 28-year-old man who comes to the office, bilateral skin lesions, both sides, on the posterior surface of the elbow. So these are the extensor surfaces. And these lesions are itchy. They use topical moisturizers, which have reduced the itching, but the lesion's still there. There's no chronic medical problems, no medications. The biopsy of the lesion shows hyperkeratosis, parakeratosis, and dilated capillaries in the papillary derme. Hyperkeratosis, parakeratosis, which means there's a thick, dry layer on top of it. Hyperkeratosis, thick, dry layer. Dilated capillaries in the dermal papillae, and a foci of neutrophils in the superficial epidermis. Which of the following is the most likely diagnosis? It is a condition we haven't discussed yet. This is a new condition. Yep, it is D. It is psoriasis. So what makes the psoriasis? Itchy lesions, hyperkeratosis, parakeratosis, dilated capillaries in the dermal papillae. So and neutrophils in the superficial dermis. These are all very, very characteristic of psoriasis. Let's discuss a little more about it. All right, psoriasis patients can be of any age. It can be associated with arthritis, as you know, but just in addition to the MSK aspect of it, I guess, psoriatic arthritis, most of the time, the patient first has the psoriatic skin lesion, and then they develop the arthritis. So associated with arthritis, and the patient would have myopathy, enteropathy, which is the GI disturbance. It could be due to a spondylitic joint condition or even AIDS. And once again, where was the lesion? It was in the posterior surface of the elbows, which means an extensor surface. It could be the scalp, as you can see in this image right here. This is extensor surface. Flexor surfaces is eczema and dermatitis, atopic dermatitis or eczematous conditions are usually on flexor surfaces. And what else? Like erythema multiforme, these are not specifically for extensor or flexor conditions. The surfaces, the ones we discussed here, these could be starting from the face, the chest, and so on and so forth. But eczema is very typical for flexor surfaces, and psoriasis is in the extensor surfaces, the forehead, the scalp, and whatnot. Yes, is that clear? Amazing. All right. So, okay. So it should be in the extensor surfaces, scalp, lumbosacral area, which is on the lower back, intragluteal cleft, even lower on the lower back, on the glans penis, And the most characteristic image that you can see is salmon-colored plaque with loose silver white scale. So you see you see this shiny silver scale that is very, very typical for psoriasis. If you see it, you have the diagnosis. And in the picture in the middle, you see that there is a pink lesion, which is a plaque. A plaque means pretty much a large macule. It's like a big flat lesion. And it could be symmetric, it could be asymmetric, usually asymmetric. And it is salmon colored or like pink colored. The patient will have erythema all over the body. And two more very, very typical signs of psoriasis is onycholysis and nail pitting. And I'll show you pictures of it very soon. There could be pustules, but usually the presentation is like this. It's risky because it could lead to secondary infection, fever, leukocytosis, diffuse cutaneous mucosal pustules, electrolyte disturbances, and in those situations, it can be very life-threatening. One important thing to remember is that if the question describes that the patient has an HLA-C, whatever association, it is a risk for psoriasis. There are both CD4 and CD8 cells involved. So there is cytokines from both CD4 and CD8 lymphocytes involved. But TNF-alpha is the most common mediator, most important mediator. Koebner phenomenon is also noticed in psoriasis. What is Koebner phenomenon? It's pretty much, patients with this genetic predisposition, if they have like a trauma on their arm, pretty much, it comes after trauma. So Koebner phenomena is positive for psoriasis. So patients with this genetic predisposition, if they have a trauma, there is a chance that they could develop psoriatic lesions. More things about psoriasis. There is a layer of parakeratosis because, as you can see, it is a thick upper layer. So whenever there's a description of hyperkeratosis or parakeratosis, that means there's a thick, rough, dry layer on top. These little bumpy thingies, there are rete pegs or rete ridges. They're both the same thing, if you're confused about that. Rete pegs or rete ridges. And yeah, there is elongation of them. And Auspitz sign is when you peel off the scales, there is pinpoint bleeding. It's not like rush of blood, it's pinpoint bleeding that happens when you peel off the scale. That is Auspitz sign, and it's positive Auspitz sign in psoriasis. It's very characteristic. And in the histology, you also see, as you mentioned, there is foci of neutrophils. So in the histology, you see neutrophil aggregates, which are Monro microabscesses, which are on the top in the parakeratosis scales. Spongiform pustules is pretty much the same thing, which is a neutrophil aggregate, but it is deeper inside. So the spongiform pustules are the ones that are below the layer of keratin. Is that all clear, guys? Amazing. All right, so one more question. All right, is anyone willing to read the question?
A 23-year-old woman comes to the physician because she's embarrassed about the appearance of her nails. She has no history of serious illness and takes well. A photograph of the nails is shown. Which of the following additional findings is most likely in this patient? I think she has psoriasis. So
Yep.
This would just be
It
like
is psoriasis. Sorry?
So the slide that you showed before, it would be on the
Yeah.
extensor surfaces.
Mm-hmm. Yep. So yeah, it is silvery plaques on extensor surfaces. It is psoriasis, and the picture shown here is
Onycholysis.
Onycholysis is the one below, where the layers of the nails just start falling out, or like start getting removed from the skin or from your body. When the nails start like falling out, that's onycholysis. Onycho means nail, lysis means breakage or like cutting out. So yeah, that's pretty much self-explanatory. Onycholysis, nail breakaway. And the picture above is nail pitting. You see these tiny dots on top of the nails? That's nail pitting. Both of these are very characteristic of psoriasis. Is psoriasis clear for everyone? Alrighty. So we have a 34-year-old man this time who comes to the physician for an evaluation of a rash on the elbows for several months. So a biopsy of the affected area showed a thin stratum granulosum, as well as retained nuclei and spongiotic clusters of neutrophils in the stratum corneum. This patient's skin findings are most likely associated with which of the following conditions? Anyone have any clue? Yep, it is B. It is seronegative spondyloarthritis because what this patient has is psoriatic arthritis, and you can see that the rash on the extensor surface and the thin stratum granulosum, retained nuclei, spongiotic clusters of neutrophils, very characteristic of psoriasis. In the stratum corneum, very characteristic of psoriasis, gives it away. It is psoriatic arthritis, and it is associated with seronegative spondyloarthropathies. So I added this image here for psoriatic arthritis. A lot of it is not in the scope of this presentation, but so I'm just going to leave it right here. If you want to go through it, it just talks to you about psoriasis, psoriatic arthritis. And yes, morning stiffness, very important, by the way. All right, next question. 42-year-old man comes to the physician with a 3-month history of itchy rash on his face. 6 months ago, he was diagnosed with early onset Parkinson's disease. His only medication is pramipexole. Physical examination shows the findings seen in the photo. There's copious dandruff on his scalp and without underlying erythema. Which of the following is the most likely diagnosis? Yes, the answer is C. It is seborrheic dermatitis, and there are pretty giveaway signs on here. History of Parkinson's disease, seborrheic dermatitis, copious dandruff, very much seborrheic dermatitis. And it is a pruritic rash, and seborrheic dermatitis affects the sebaceous areas, which are the areas that are likely to sweat, like your face, your eyelids, your scalp. These are areas that have areas that can sweat. So yeah, this kind of the location of seborrheic dermatitis happens in those areas. A lot of these cases are idiopathic, but there's an increased predisposition of seborrheic dermatitis in patients with HIV or even neurological conditions like Parkinson's disease. So if a patient with a neurological condition like Alzheimer's, Parkinson's, or HIV comes up, or even a stroke comes up with dandruff on his scalp and also itchy rash, it is seborrheic dermatitis. And it could also be associated with patients with malabsorption syndromes in their GI. Yeah, and it's pretty characteristic. It's yeah. So to discuss a little bit more about seborrheic dermatitis, like I mentioned, it involves areas where the scalp is areas where there's more sweating, like the scalp, the forehead, external auditory canal, retroauricular area, which is the area behind your ears, nasolabial folds, or even the area right above your sternum, which is the presternal area. It is not a disease of the glands themselves. Don't get it wrong. It is not a disease of the sebaceous glands, but it is just predisposes, or it's more in those areas. That's what you got to know. Dandruff it's pretty much very obvious for it's an important point for seborrheic dermatitis. And infants with the seborrheic dermatitis can have diarrhea and failure to thrive, associated with Parkinson's or neurological conditions. Treatment with levodopa, as you can see, the patient does not take levodopa. They're taking pramipexole. So treatment with levodopa does help because, from this the association being made is that when the Parkinson's or the condition itself is improved, it is also improved. The seborrheic dermatitis is also improved. It can also be seen in patients with HIV. And in the histology, you see that there is a big mound, a circle, a little lump of parakeratosis. And this has neutrophils in them. It has also serum in them. And there is perivascular infiltration, but this is the most characteristic histological sign, a little mound of parakeratosis. In patients with HIV, you see plasma cells. A lot of HIV-associated infections or HIV-associated conditions, you see plasma cells. There is apoptotic keratinocytes, and the treatment is using ketoconazole. And it's associated with this. I don't know if is it a bacteria? Is Melanocytic for a bacteria? I'm not sure. It is associated with it's a fungus. I'm sure it's a fungus. So treatment with Malassezia, treatment of Malassezia furfur or an infection with Malassezia furfur is also associated with seborrheic dermatitis. So the treatment with ketoconazole helps, or the treatment of Malassezia furfur stops the seborrheic dermatitis, but it can also be used for later on. A lot of people take ketoconazole for dandruff as well, unrelated to their fungal infection with Malassezia furfur. All right, so is that clear? Great. So we have a 25-year-old woman who comes to the office with a 4-week history of a pruritic skin rash. The patient has no chronic medical conditions, no medication, and on examination, there are pink papules distributed symmetrically over the anterior surface of the shins and the ankles. They shaved it, and the biopsy of it shows hyperkeratosis along with a thick granular layer. In addition, there's a band-like infiltrate of mononuclear cells, predominantly lymphocyte, and the subjacent superficial dermis that involves the overlying dermis. This, we already discussed this little line, by the way. We discussed this line, band-like infiltration of mononuclear cells, predominantly lymphocytes. The rete ridges are sharpened, sawtooth appearance. This is very characteristic of this condition. The basal layer of the epidermis is degenerated with scattered colloid bodies. Which of the following is the diagnosis? Yes, it is Lichen planus. It is D. All right, so what exactly is this? I've mentioned this already, which is what I'm asking. In addition, there's band-like infiltrate of mononuclear cells, predominantly lymphocytes, and a subadjacent superficial dermis that involves the overlying epidermis. What exactly is being described here? No, actually, it's not psoriasis. I'm emphasizing on this because I remember getting a question on it in my MSI final. I don't know if I'm sure. It's what's being described here is interface dermatitis, which is associated with lichen planus, and the other condition was, who remembers the other condition that has interface dermatitis? Erythema multiforme. Both of these have interface dermatitis, which is pretty much the infiltration of lymphocytes in the layer between the epidermis and the dermis. So it's in lichen planus, very characteristic, and erythema multiforme. Actually, I'm not sure if psoriasis has it as well, but these are the most characteristic ones. So yeah, lichen planus, the most giveaway aspect of it can be described by 6 P's. It is pruritic, it is itchy, it is purple, it is polygonal, it's not a square or a circle, it is polygonal, it is flat, it is planar, papules, and plaques. So it could be described by 6 P's. It is self-limited, it comes and goes. There could be oral lesions in these patients with the risk for squamous cell carcinoma. The patient could have in their gums or near their teeth, there could be like white net-like lesions. It's called leukoplakia, and it's lichen planus, and it could lead to squamous cell carcinoma. And patients with darker pigmentation, they could have it can have darker presentations rather than whiter ones. And these white markings, they're called Wickham striae. It is symmetrical, that is characteristic of it. And this one also has Kobner phenomenon, which is, once again, when you have trauma, there's a chance that this patient could develop lichen planus. So I guess that's something in common with psoriasis, with the lichen planus. There is characteristic sawtooth appearance in this. As you can see, this one's a bit too rounded to be a saw, but anyways, this one's sharp enough to be considered a saw. So it's like, that's what it looks like in the histo. So characteristic sawtooth appearance, usually it's, when they mention it, it's usually seen in your question vignette. So when you see that, you know it's lichen planus. Once again, it is a condition with interface dermatitis where lymphocytes are along the layer, between the layers of dermis and the epidermis. There's a band-like lymphocytic infiltration, very characteristic of lichen planus. There is a hypergranular layer and a hyperkeratosis layer, which is why on top it is dry. Pruritic, purple, polygonal, planar, papules, and plaques. All 6 P's. So look for P's. It is lichen planus. And the question could also describe that the patient has a white lesion in their mouth. So another thing pointing out to lichen planus. All right. So a previously healthy 46-year-old comes to the physician because of an itchy rash on her leg. She denies any recent trauma, insect bites, or travel. Her vital signs are within the normal limits. Examination of the oral cavity shows white lace-like lines on the buccal mucosa. That says a lot. Photograph of the rash is shown. A biopsy specimen of the skin lesion is most likely. Which is following? What do you think this is? Read all the options. Once again, it is C. Lymphocytes at the dermo-epidermal junction, interface dermatitis, very, very characteristic of, yes, interface dermatitis, erythema multiforme, and lichen planus. Interface dermatitis is pretty much lymphocytes at the layer between dermis and epidermis. When you see that, that is lichen planus or erythema multiforme. But with this patient, you can see that this is polygonal, pruritic, right? It is itchy, pruritic, polygonal, all the P's. It's, yeah. Let me go back to the list again. Pruritic, purple, dark, reddish, planar, flat, papules, and plaques. It could develop into papules even if it's flat, but mostly it's flat. And also plaques. So this description plus lymphocytes in between the dermis and the epidermis, it is lichen planus. Is everything clear so far? All right. Question number 20. We have a 70-year-old man who comes to the physician because of painless skin lesion on his neck for the past 5 months. The lesion has gradually become darker in color and is often pruritic. He has a similar lesion on the back. He is a retired landscaper. He has smoked half a pack of cigarettes daily for 45 years. Physical examination shows a 0.9 centimeter hyperpigmented papule on the neck with the greasy, wax-like, and stuck-on appearance. Histopathological examination most likely shows which of the following? And yes, the answer is C. It is seborrheic keratosis. What gives it away? Keratosis, yeah, keratitis. So, yeah, what gives it away? It is stuck-on appearance. It is greasy wax-like. It becomes darker. It is pruritic. It's a very old man. It's painless, and he has a similar lesion on his back. And this is an image. It looks like a little bug stuck on it. So yeah, that's pretty hands-on for seborrheic keratosis. Let's discuss it a little bit more. All right, so seborrheic keratosis, it appears in middle-aged and older patients. Once again, it has a waxy, stuck-on appearance. It can be dark, it can be very small. It is exophytic, which means it is a little bulge on the outside. It looks like a little piece on the outside. Multiple lesions can be seen on the face. It's called dermatosis papulosa nigra. You guys have seen Morgan Freeman's face. He's got like, a bunch of stuff on his face. So that could be dermatosis papulosa nigra. And they are small, stuck-on little bumps on his face. And in the histology, you see horn cysts. These little white cauliflower-looking thingies. I should be a pathologist. I came up with that right now. Cauliflower. Wait, am I thinking cauliflower? Yes, cauliflower. Yes. So these are regions of hyperkeratosis, and these are called horn cysts. And in these patients, there is a mutation. It's the tyrosine kinase mutation, which is the FGFR3 mutation, is associated with seborrheic keratosis. It is a tyrosine kinase mutation. That's the way to summarize it, honestly. And I mentioned earlier, there are certain skin conditions that are heavily associated with malignancies. And seborrheic keratosis is the most, I would say, trademark skin manifestation associated with a malignancy, my opinion, at least for board's perspective. Because if you see that a patient with a lot of seborrheic keratosis, like this patient right here on the right, you see a bunch of bumps and a bunch of lesions on their face. It is highly associated with GI cancers, especially gastric cancer. So if for your step 1 exam, it could have a scenario like this where a patient with a GI cancer, what other manifestation does he have? Or the other way around, there's this patient with a bunch of seborrheic keratosis on their face, stuck on exophatic lesions on their body. And yeah, this particular sign is called the lesser Chelat sign. You could also have a question like this on Sunday, where it is a patient with gastric cancer, and they describe the condition pretty much. Like they say that they're stuck on waxy little lesions all over the patient's trunk, and they ask you, what is this sign called? Or like, it is the lesser Chelat sign. All good so far, guys? All right. The next condition we have is a 23-year-old woman who comes to the physician for an annual maintenance examination. She feels well. She is 155 centimeters tall and weighs 79 kgs, which just means that she has a very high BMI, and she shows a skin rash over both axillae, and a photograph of her left axillae is shown. All right, as you can see the image here. And which of these following skin conditions is this associated with? From the list. It is F. It is diabetes, because what we're looking at here is Acanthosis nigricans. I'll be honest with you, the original question said diabetes was not one of the options. Although it does cause it, I replaced it because this is a condition you're more familiar with. The original option said polycystic ovary disease. So Acanthosis nigricans is heavily associated with polycystic ovary disease and type 2 diabetes mellitus. This vignette fits a patient with diabetes, so it works either way. But GI adenocarcinoma is associated with seborrheic keratosis. And actually, malignancy can also cause Acanthosis nigricans. So, what's most characteristic, but it is not as common. When you see a question with a better answer, like a better answer in this case would be type 2 diabetes or polycystic ovary disease. They would never put type 2 diabetes or diabetes and polycystic ovary disease in the same question. Like you will never see them together because they're both very, very good answers for Acanthosis nigricans. So yeah, but if GI malignancy is one of the options, it is a good answer, but diabetes is the better answer. Or diabetes or polycystic ovary disease or PCOS. All right, and yeah, next question. All right, so we have a patient with who is 76 years old, type 2 diabetes mellitus, comes to the physician for a follow-up examination, feels well overall, but is concerned about some lesions on his neck that his wife noticed. He is 84 kgs, 165 centimeters, 31 BMI. He's overweight, obese. Lesion scattered across his neck and axilla, and a photograph of the lesion is shown. Which of the following is the most likely diagnosis? Yes, the answer is skin tags or fibroepithelial polyps. Or okay, that's wrong. It's not warts. It's it's D. I'll fix it before I send you guys. It's D. It's skin tags. So yeah, to quickly go over both these conditions that we just saw. Also, little clarification, I just realized. This mentions gastric malignant lymphoma. Gastric malignant lymphoma is not associated with Acanthosis nigricans. It is gastric adenocarcinoma. They're both different gastric tumors. So yeah, it's a common misconception, but malignant lymphoma is not associated with gastric Acanthosis nigricans. But if it said gastric adenocarcinoma, that would be the right answer. But at the same time, I'm of the opinion that diabetes and PCOS is still the better answer. So I doubt that they would put all three or any two of them together in the same question. So you won't have to worry about it. Just keep these three in mind: diabetes mellitus, polycystic ovary disease, and gastric adenocarcinoma. Gastric adenocarcinoma is also associated with seborrheic keratosis. Anyways, this is wrong. I'll fix it before I send it to you guys. All right, so Acanthosis nigricans, thick, velvety skin, as you saw earlier. And it happens in flexor areas. Once again, there's another condition in flexor areas. But most of the time, when you get a question like this, it's going to be either on the neck or in the armpit, neck, armpit. It's associated with obesity and diabetes. Also, polycystic ovary syndrome. I changed the question because I'm not sure if you've taken PCOS yet. Maybe in COM, but I'm not sure. So yeah, hyperkeratosis with repeated peaks and valleys, as you can see. It's kind of like a pretty picture, you know, it's like a little mountain range. Yeah, so this is very characteristic for Acanthosis nigricans. Fibroepithelial polyps or skin tags, they're also called squamous papillomas, but usually you'll just see both these names. Mostly skin tags, because who likes to say fibroepithelial polyps? They are benign, they're cosmetic, they're associated with diabetes, obesity, intestinal polyposis. Our question earlier, the patient was obese as well. So yeah, also it could be associated with diabetes. And most in your exam, the questions are the question would most likely describe a fat patient, like our patient here. Yeah, this patient had 31 BMI, but I myself saw a patient in the hospital who was he might have been diabetic. I saw him in a family medicine clinic. He came to remove a skin tag. He's had multiple skin tags, so he was probably diabetic. So he wasn't obese, and yeah, it could also be seen. A lot of the stuff that you learn in your preclinical years, there tends to be a variation in the real life experience. Anyways, it is in middle-aged or older patients. You can see it in the trunk, neck, face. It has a fibrovascular core covered in squamous epithelium, as you can see here. The pale white core, it's and covered by squamous epithelium. It's a very characteristic appearance. It's very jagged. I don't think you're going to be shown a histology for a question like this. If you're going to have a question on skin tags, it's going to be describing the net and then show you an actual picture of the skin tag. All right, we're getting close. All right, so we have a patient. He is 28 years old, previously healthy woman. She is a 28-year-old, previously healthy woman, comes to the office for evaluation of a raised pigmented lesion on her leg. The patient has had no itching or pain, cannot remember how long she has had this lesion. She's used tanning machines a few times in the past, but denies excessive sun exposure. She's particularly concerned about risk of malignancy, and as her father was recently diagnosed with skin cancer. Skin examination shows a nodule seen in the image below. So, and yes, the answer is B. As you can see, a lot of people did think it was C, junctional nevi, but it is compound melanocytic nevi. Let's discuss what makes them apart in a bit. Yeah, this is also a compound this is a junctional nevi, actually. So that's the confusion. So this one is flatter. In the picture, it looks flatter, but it's supposed to be a little bumpy. I guess you can appreciate a little bump in here. So this second picture is junctional nevi. Yeah. But the best way to remember it is that compound is a papule, it is bumpy, it is a big round ball. And junctional is flat, it is a macule. All right, so let's quickly discuss melanocytic nevus. They're moles. So if you have a mole that is a melanocytic nevus, don't worry, it's not cancer. I hope not. Anyways, the word nevus implies a congenital. This is from your lecture. The word nevus implies congenital, but it is not always congenital. A lot of these are acquired. The congenital nevus, as you can see here, these are called giant congenital nevuses actually, because as you can see, it is pretty damn huge. It is a big dark layer. Usually it regresses on its own. So compound nevi looks like junctional, but are raised. Yeah, so they look like junctional, but they are the raised variants. Excuse me 1 second. Yeah, and I have pictures here to compare the both. Junctional is flat, compound is raised. Intradermal are bumpy ones that could be right in between them. Like it's like a layer of a dark bump, symmetrical circle. It's not exactly a big bump, but it's not exactly flat. That is intradermal. Blue nevi are benign. Halo nevi are also benign. And these are all neoplasms, and they all have a mutation in BRAF or NRAS. They're both activating mutations. The expression limits proliferation, and how they function is by inducing growth arrest by inhibiting CDK4, and 6 by accumulation of P16 and INK4A. INK4A is important. P16 INK4A is important because most of these something to do with melanocyte, melanoma. They all have something to do with INK4A, and it's easy to remember because ink, and ink dark melanocyte nevis or melanomas are dark. So they induce growth arrest by inhibiting CDK4 and 6, and by accumulation of P16 INK4A. And that's their function. And disruption in this particular pathway, in the BRAF and RAS activation pathway, can predispose the patients to melanoma. So this leads us to a different kind of melanocytic nevus, which is dysplastic nevus. Point to remember, it is bad. The image right here on the right, it is a bit misleading, but that's the image on your lecture. That's why I put it in for dysplastic nevus. Because this looks very symmetrical and looks almost benign. It looks like a compound nevus or intradermal nevus, but at the same time, it is dysplastic because it's not perfectly circular. There is a layer of lightness around it. There's a layer of darkness in the center. It is bumpy. It is messy. And some patients could have something called the dysplastic nevus syndrome, where there is multiple of those, as you can see in this image right here. And patients with DNS or dysplastic nevus syndrome have a good chance, a 50% chance of developing melanoma by age of 60, or even multiple melanomas. And these are the autosomal dominant inheritance. So multiple melanomas, I mean, like they could have one dysplastic nevus here, one dysplastic nevus here, and they're both becoming melanomas. Pretty awful. The mutation here is once again on CDKN, CDKN2A on 9p21, and CDK4 on 12q14 mutation. On its own, it's pretty chill if it's 1 or 2. Usually, it's not problematic. But if it's multiple dysplastic nevus syndrome, you see multiple of them, very, very huge red flag. It could lead to I'm sorry, I don't get your question. What was the CDKN2B the clinical mentioned at some point? Oh, was it mentioned in this lecture? Because I'll be honest with you guys, the gene stuff, like I don't think it's been involved with any of the conditions so far. If I do notice it, I can let you know later. But CDKN2B, I don't think I mentioned it. I don't remember it, honestly. I'm sorry. Let's go back. All right. Oh, okay. CDKN2B, I'm not sure. Maybe it's later on because I wasn't memorizing the mutations, to be very honest. All right. So you see architectural and cytological changes. Bad sign, and that's what makes it dysplastic. So as you can see, it's a complete mess. The previous images you saw for different conditions, you saw that there are like layers. You could still appreciate some level of layering to it. There's the epidermis, there's the dermis, maybe a little bit of funk on the side, but the pictures you see here, it's all over the place. So there is architectural and cytological changes. Cytological changes being changes in the cells themselves. On the picture on the right, you can appreciate what are called nevi nests. If you can see my laser, pointing out to one, it looks like a nest. They are nevi nests. The atypical changes you can see are nuclear enlargement. You see some nuclear, as you can see, there's like a darker one here. That is nuclear enlargement. They are irregular. They are often angulated, which means that they are not, it's pretty much structural abnormality, pretty much. You can see contours on the nucleus, and some are much darker than the others, which is hyperchromasia. There is, you can also appreciate lentiginous hyperplasia. The word lentiginous means something to do with the melanin. Lentiginous means melanin. So lentiginous hyperplasia pretty much means that the melanin cells or the melanocytes are hyperplased and there's more melanin seen, which is very characteristic of melanocytic nevus or melanoma. So once again, the superficial dermis has lymphocytes, melanin incontinence because of, the hyperplasia. And there's also, you can also appreciate some fibrosis. There's linear fibrosis can also be seen in dysplastic nevus. All right, so we have a question here. A 32-year-old woman comes to the physician for a routine examination. She has no history of serious medical condition. She appears well. Physical examination shows several hundred pigmented lesions on the back and the upper extremities. A photograph of the lesion is shown, and the remainder of the exam shows no abnormalities. The patient is at risk of developing a tumor with which of these following findings? What do you think it is? All right, it is C, actually. It is S100 positive epithelioid cells with fine granules. So, okay, when you mentioned B, you must had, yeah, it is melanoma. S100 is very, very typical, or like it's a very important marker for melanoma. S100 means melanoma. Why is it not B? Keratin pearls are not seen in melanoma. Keratin pearls are more characteristic of squamous cell pearls, keratin pearls. So S100 is melanoma pretty much. So S100 positive epithelioid cells with fine granules. So this patient right here, she has multiple dysplastic lesions. She probably has dysplastic nevus syndrome. So she's at a higher risk of developing melanoma. All right, so we have a 79-year-old woman, old, comes to the office due to bleeding from an ulcerative lesion on her right nipple. The lesion is itchy, has been there for several months, has been increasing in size. Examination shows a crusty, thickened erythematous and ulcerated nodule with evidence of hyperpigmentation. Changes also extend to surrounding areola. The excisional biopsy was done, and it shows a relatively well-circumcised aggregate of large polygonal pleomorphic cells with abundant mitotic activity and surrounding necrosis. S100 and HMB45 stains are diffusely positive. You are right, it is melanoma. And there are a few things. This is a very, very obvious question. I don't know how only 62% got it right. It is a 79-year-old woman, old woman, bleeding ulcerative lesion, increasing in size, itchy, and it is crusty, thick, evidence of hyperpigmentation. So 1, 2, 3 well-circumcised aggregates of pleomorphic large. This shows that it is a pretty bad non-benign cancer. That's what all this means. Large polygonal pleomorphic cells with abundant mitotic activity and surrounding necrosis. It just shows that this is a very, very dangerous cancer. And these two stains, S100 and HMB45, are very, very typical for melanoma. All right. So for melanoma, you can identify it by A, B, C, D, E. This is a very, very good abbreviation, honestly. It kind of like summarizes melanoma for you. The lesions are asymmetric, as you can see in the picture right here. They're asymmetric. There's irregularities in the border and uneven edges. In some areas, the pigment's fading off. There's variable colors. Sometimes it's brown, tan, black, red. It's not a single black lesion that you're expected to see. They're large, and the diameter is over 6 millimeters. Excuse me. Okay, never mind. Okay, diameter is over 6 millimeters. It is larger, and it changes in size, like we saw in the patient before. The size increases, the color increases, the shape changes. So these unstable dark lesions, very, very typical for melanoma, asymmetric and whatnot. These are deadly. Melanoma is very, very dangerous. They can metastasize and usually to brain and the lungs. You can have a patient present with, they could describe maybe a couple things about a skin lesion and then about the skin lesion, and they can say, okay, this patient had a seizure. It's an older patient. He had a seizure, or he starts coughing up blood. And they describe melanoma a little bit. So now you know, the cough and the seizure are due to metastasis to the brain, to the lungs and the brain, respectively. It could be itchy, it could be painful, and the growth is first radial and then radial to the sides, and then vertical upwards, or actually downwards. And the vertical growth is a very, very bad prognosis. I'll discuss the growth in a little bit. Deeper or more vertical, more chance of metastasis. Why is that? Because the more down it goes, the more vertical it goes, the closer it gets to blood vessels. And once it gets to blood vessels, it can hematogenously spread to other organs like the brain or the lungs and spread metastasis. Lentigo maligna is a type of melanoma where there are facial lesions and they're seen on older men. Usually they are in the radial phase. And acral and mucosal lentiginous melanoma. Acral or mucosal lentiginous melanoma, these are not related to sun exposure. Usually patients with melanoma, there is a history of sun exposure and UV-related damage to the cells, which leads to melanoma. But with these patients, or acral mucosal lentiginous melanoma, it happens in people with much, much darker pigmentation, like Black people. And it is unrelated to sun exposure. And yeah, I think you might have a question on this, because I remember having a question on this, and this condition is more, if I remember right, it's better described in your clinical lectures. Acral mucosal lentiginous melanoma, related to Black people. And histology, you'll have a large nuclei, irregular contour, clumped chromatin, and red or eosinophilic nuclei. Let me try to find, yeah, as you can see, this nuclei right here, it's red, giving it away. That is a very characteristic histological sign of melanoma. The prognosis, once again, as you must already know, the depth makes a huge difference. The more mitosis there is, worse. More depth, worse. Tumor regression, I'll discuss what that is in a second. Tumor regression is where the color starts disappearing. It becomes white in like a certain area of the tumor. This is a bad sign. It might sound like a good thing, but it is a bad sign where a little area becomes whiter. In the biopsy, if you see there is more tumor infiltrating lymphocytes, that is a good sign. That just means that it has a better prognosis. But that's the one good thing out of all this. Depth, more depth, bad. Number of mitosis, increased number of mitosis, bad. Tumor regression, bad. Male gender has it more, and it also has the worst prognosis. And the more central, if it's on your face, chest, the abdomen, those have a worse prognosis. If the lesion is on the extremities, that is a better prognosis. All right, to quickly go over the development. In A, you see lentiginous melanocytic hyperplasia, which was discussed earlier. As you can see in dysplastic nevus, this is the most basic form. The dysplastic nevus stage of a melanoma, or a possible melanoma, you see lentiginous hyperplasia, which are the melanin cells being hyperplased or growing, or more than it's supposed to be. Later on, you see it becomes a nevus. So A and B, it is still in the dysplastic nevus stage. And by B, it is a full-fledged dysplastic nevus. And you see that there are barely any melanin cells, but you see some hyperplasia. They are going outside. And by C, things are getting worse. Or the third picture, it becomes a lentiginous compound nevus, or it is a full-fledged dysplastic nevus. So as you can see, at this stage, it gives away your typical presentation of a dysplastic nevus. There are more melanocytes up there, and there's more hyperplasia. And now by D, you see what we described as radial growth. Radial growth is pretty much when the melanocytes, or the hyperplased, the dysplastic cells, they go to the sides. Rather than up or down, they start spreading wide, which is why the size increases. So when it spreads to the size increases, and this is still in the radial growth stage, which is still not too terrible. It's bad, but it's not too bad. But by E, there is vertical growth. And with more vertical growth, there is a worse stage. It implies a worse stage of melanoma, and it implies a higher risk of metastasis. And the study being used for this is called a Berlow thickness study, where you get you guys know about the section you take, and you check the infiltration of the melanoma. And the more infiltration there is, the worse the prognosis. All right, So a little bit more about melanoma. It is a big deal. The biggest risk factor are genetics and sun exposure, and 10 to 15% are genetics is what you usually see in the acral lentiginous example, for example, in Black people. But the regular garden variety or the sun exposure variety are more common in lighter individuals. And HMB 45 or HMB, there's nothing else to confuse you with. So HMB and S100 stain positive lesions are very characteristic for melanoma. So if they mention either of these, you don't need to think twice. If it's positive, it's melanoma. Yeah, this is what you were talking about. Okay. So yeah, CDKN2A is in melanoma. And once again, INK4A mutation. So yeah, I guess now it's easier to remember because CDKN2A is in dysplastic nevus. CDKN2A is in melanoma. So this is a common mutation, and INK4A mutation is also seen. So, and mutations that suppress the retinoblastoma gene are also seen in patients with melanoma. Retinoblastoma gene is another tumor suppressing gene like p53. So when it is suppressed, there's a higher chance of melanoma. And this is what I was talking about, tumor regression. Tumor regression is where, you see this tiny area where it's not dark anymore. It used to be dark, but there is this area where it's relatively less dark. It's like a lighter area in edge of corners. This is bad. It's not a good sign. There are activation mutations that could also be seen in RAS, BRAF, PI3K, PTEN, CDK4, P12, c-KIT. Activating mutation in any of these is bad. But a suppressing mutation in RB is also bad because RB is a tumor suppressor gene. And CDKN2A, you can remember for melanoma and dysplastic nevus. All right, so next question. We have a 44-year-old African-American woman who comes to the physician for a routine examination. She is concerned about cancer because her uncle died of metastatic melanoma a year ago. She has no history of serious illness, does not take any medication. She has been working on a law firm for the past 20 years, travels to the Caribbean. The woman is at the greatest risk of which of the following type of melanoma? So it's B. Yes, it is acral lentiginous because this patient is African American. Sun exposure does not matter. There is family history giving more reason for it to be a genetic melanoma condition. So yeah, it is acral lentiginous melanoma because it's an African American patient and there is no relevant like sun exposure history or any of that. Except she visits the Caribbean. It does make the chances worse, is all I would say. But the main predisposing factor for acral lentiginous melanoma is their genetics and family history. This is an example for how it presents. You can see it on the nails. I think there's also an image in your clinical lecture where it is a melanoma lesion on your nails. All right, next question. We're almost at the end. So there's an otherwise healthy 66-year-old man who comes to the physician for evaluation of rough skin over his forehead and the back of his hands. He has tried applying different types of moisturizers with no improvement. He has worked on a farm all his life. So what does working on a farm all his life mean? That means more outdoor, more sun exposure. Yes, exactly. So a physical examination shows 2 erythematous papules with a gritty texture and a central scale over the left temple, and 3 similar lesions on the dorsum. The patient's skin lesions increase the risk of developing a skin condition characterized by which of the following histopathological findings? Someone said atypical melanocytes, but look at the image. Also, it's on his forehead and the back of his hands. Different types of moisturizer, no improvement. Gritty texture. It's a gritty texture with central scale. So, and the image itself, none of this really indicates melanoma or something to do with melanin. So, it is keratin pearls. So what we're dealing with is actinic keratosis. And this can lead to squamous cell carcinoma. So yeah. So as you can see, there are a few things that give it away. There is a sun exposure. Just so you know, this is a premature information. All kinds of skin cancer has sun exposure. Basal cell carcinoma, squamous cell carcinoma, melanoma, unless it's genetic, they're all involved with sun exposure. More sun exposure, more risk for squamous for skin cancer. So wear your SPF, I guess. So, anyways, especially if you're someone with lighter skin. So as you can see, this patient has like these gritty central scaling, like kind of like a scaled lesion, and it's on his forehead, and you see similar lesions on the dorsum of his hands too. And this indicates keratin pearls, and that's pretty much actinic keratosis, which is pre-malignant for squamous cell carcinoma. So let's discuss actinic keratosis a little bit. So these are small, rough, tan, and red or skin-colored lesions. They can produce horns like this. Like the picture earlier, it is flat, kind of flat, and even the forehead right here, it is nothing too serious. It's still flat. It just looks a lot like dirt. It just looks not good. But it could also develop into a little horn like this. So this just indicates the crazy level of parakeratosis and thick elastic fibers development, or elastosis. So yeah. So they're dry. They could be on the back of your hand, on your forehead. They can form horns on sun-exposed sites, especially. And if it's on the lips, it is called actinic cheilitis. The cheilitis, or whatever to do with the cheili, means to the lips. And it could be associated with radiation, arsenic, hydrocarbons, someone working on a chemical plant. That could be a vignette you could have, where a lot of these are involved. It could also increase the risk for squamous cell carcinoma and actinic keratosis. There is cytological atypia. You see hyperplasia of basal cells. As you can see, these longer cells, they are hyperplasic. They're bigger. They're all over the place. And you can see this crazy layer of keratin, hyperkeratosis, and it layers up so much that it could form into a little horn like that. So that happens in the superficial dermis, and there's also thick elastic fibers also formed. So it can, if it's like in a horn, you can move around, and it just, it could be a little flexible. And most important thing, actinic keratosis can lead to squamous cell carcinoma. And imiquinod is used for the treatment of actinic keratosis to get rid of it as soon as possible. So remember the name imiquinod. So we have a very obvious picture of something terrible going on. So it's a 58-year-old white male. White people are more predisposed to skin cancers. So, and the patient has hypertension, type 2 diabetes mellitus, and comes to the physician because of a 3-month history of a painless lesion on the lower lip. He has smoked 1 pack of cigarettes daily for 20 years, another risk factor for cancer. He has worked as a fruit picker for the past 25 years. Outdoor exposure. His current medication include captopril, metformin. Oral cavity shows a single ulcer near the vermilion border. Vermilion border is the edges, pretty much. Which of the following is the diagnosis? Very straightforward answer. This is squamous cell carcinoma. I'll tell you how you can differentiate between the two of them very soon. Someone said basal cell carcinoma. It is squamous cell carcinoma. Because of the smoking history, any type of cancer at all, the smoking history is a red flag. And also one more important thing, it's a little off topic, but I'll just mention it. If you see keratin pearls or anything to do with keratin, you must have noticed this already. It means squamous cell carcinoma. Thought I'll put that out there. So it shows a single ulcer near the lip, sun exposure, smoking, painless lesion. All of this is very typical for squamous cell carcinoma. And the patient, they don't mention a history of actinic keratosis, but it could come directly. That's all that means. But actinic keratosis, if the patient has actinic keratosis, they are at a risk for a squamous cell carcinoma. So this is the second most common lesion. So, and more often in older men and more in men, and there is a low risk of metastasis, which is a good thing. And you often see in situ tumors. In situ tumors basically means that it has not invaded the basal layer yet. So it has not broken through the skin itself, and it has not gone into the blood vessels, leading to metastasis. So with the increased occurrence of in situ tumors in these patients, and It just means that there's low risk of metastasis. Invasive squamous cell carcinoma, on the other hand, shows polygonal cells, keratin pearls, very, very characteristic of any sort of squamous cell carcinoma. It could be the skin, it could be anywhere else. Squamous cell carcinoma, keratin pearls should be in the same line. Necrosis, once again, a highly anaplastic area. All of this just shows a very, very dangerous, unstable cancer. In some cases, to really confirm the diagnosis, you might need to do keratin staining, and this just gives it away that it is a squamous cell carcinoma. When you see ulcerating lesion like this, near the lip especially, a very ulcerating lesion, very ugly lesion like this, it is very typical for squamous cell carcinoma. A little bit more on it. It happens due to DNA damage from sun or UV exposure, tars, oils, chronic ulcers, or burn scars. Yeah, if you have an old burn scar, it could lead to squamous cell carcinoma. It is a risk factor. Tobacco and betel nut chewing. Tobacco, once again, huge risk for any sort of squamous cell carcinoma. Arsenic, radiation. So keep these things in mind because they could bring you a question with any of these risk factors, such as someone who spends a lot of time outside, such as he picks fruits, if I remember right. So that's the most typical presentation that they could give you. Someone who's exposed to tars and oils a lot, someone who has chronic ulcers, someone who's a burn victim, someone who works with chemicals like arsenic, someone who's a radiologist, they work with a lot of radiation. Once again, tobacco, huge risk factor. And it could also be associated with immunosuppression, such as a patient undergoing chemo for another cancer, and someone who just had an organ transplant. People with organ transplant, they're immunosuppressed for a while so that there's no rejection. So such patients could also be at risk for squamous cell carcinoma. So there's these two mutations or two genes that is involved with most cancers. So there's the retinoblastoma gene, there's P53, RB and P53. Just remember that RB has to do with melanoma and P53 has to do with squamous cell carcinoma. Keratoacanthoma is an in situ squamous cell carcinoma. It is well defined and it has a cup shape. The image you see here is still keratoacanthoma. It is not ulcerated yet, and there's a central depression with a debris of keratin in there. This regresses spontaneously. I really like this histological image. It looks really cool. It's like symmetrical and stuff. I know it's a cancer, but you can appreciate beauty where it's due, I guess. So yeah, it's a very pretty image, and it's a little cup thing. And it's not ulcerated yet. It's still early, and there's a chance that it can regress spontaneously. Yep. The one that looks like a volcano is squamous cell carcinoma. All right. So what do we have here? A 67-year-old man comes to the physician because of a lesion on his nose. The lesion appeared 1 year ago and has slowly increased in size since then. There's no associated pain or pruritus. No pain or no pruritus, otherwise healthy, played golf every other day, sun exposure. He says that he used to like tanning beds regularly because he liked the tan look. Tanning beds, another risk factor. Photograph of the lesion is shown. Which of the following is the most likely diagnosis? Yes, it is basal cell carcinoma. So you can very easily appreciate the difference between basal cell carcinoma. It is flat. It looks way less dramatic. Squamous cell carcinoma, if you remember the picture, it is ulcerated, it is bleeding, it is painless, but it happens near the lips. Near the lips, especially with a patient with a history of tobacco, it gives away squamous cell carcinoma. That's one way you can differentiate between them, and it looks a bit more cleaner with well-defined edges. And patient who has a history of tanning salons and whatnot, it is basal cell carcinoma. So how do we tell them apart? Basal cell carcinoma are the most common one. They are slow growing. They grow much slower than, let's just see. For this patient, he has a 3-month history of a painless lesion. But with this patient, it appeared 1 year ago, but it has very, very slowly increased in size. So these are slow growing, and these happen once again in sun exposed area, lighter people. Number 2 is common for pretty much every melanoma. So keep that in mind. So this there is I could say it's a pre-malignancy sign, but I don't think so. the patient, there's a certain condition called xeroderma pigmentosum. It's another condition that is very ugly and something that you hate to see in the hospital. I've seen one patient with it. It's not pretty. It's a patient who, with a little bit of exposure from the sun, they could have like very, very terrible ulcers. It is a genetic condition, and it is a issue with DNA repair. So patients with xeroderma pigmentosum have a predilection towards basal cell carcinoma. And if you get a vignette of a patient with xeroderma pigmentosum, it is usually a much younger patient. The more advanced ones have central ulcers in between, as you can see, but they're still much cleaner, as you can see. They have central, they're called rodent ulcers, and these can invade bone. And remember that these can invade bone, but squamous cell carcinoma has less risk of metastasis. So if you get a question where it is a skin cancer, very obviously, and it is not melanoma, and they describe some sort of metastasis or some sort of non-skin related symptom, very, very good chance that it is a basal cell carcinoma, because squamous cell carcinoma usually are in situ. So in the histology, the tumor cells look like regular basal cells, as you can see. They look like regular basal cells. They're not massively inflated or any of that sort, but they are arranged in a particular palisading arrangement. Palisading arrangements, like, you know, they're just arranged in layers. That's pretty much what that means. And because of it, because of the arrangement and because of the stroma being like pulled apart because of the way the thing grows, or the tumor just, you know, starts multiplying, it separates or splits the stroma and it creates this little rift in between. I hope you can appreciate the little separation between the layers. And most of the time, squamous cell carcinoma looks like this. Basal cell carcinoma looks like this, but or a flat lesion like this, and it's very slow growing and it increases in size. But squamous cell carcinoma, on the other hand, is it's relatively faster growth, and it is ulcerated, and it looks way messier. There's two ways it can grow. There's multifocal growth and there's a nodular growth. Multifocal growth is from the epidermis and more superficial, where it's more like a radial growth. So the tumor happens, you see the mitotic changes, you see all the typical cancer cytological changes or architectural changes, and it just spreads wider. When it spreads wider, that is multifocal growth. It is, but the nodular growth, it grows downwards to the dermis. So this sticks multifocal mostly sticks to the epidermis, but nodular goes down to the dermis. And it could have mucin come up to it. It could have fibroblasts, it could have lymphocytes. And as you know, the downward it goes, the more dangerous it is. We've already discussed the histology. All right, so anyone have any questions so far? Are we all good? Amazing. So feel free to interrupt me if you have any questions or any doubts. All right, basal cell carcinoma, a few more things. There is a familial syndrome associated with this. And this is called the nevoid basal cell carcinoma, or NBCC, and it is also known as Gorlin syndrome. In this condition, these patients have multiple basal cell carcinomas all over their body. And the mutations involved it is autosomal dominant, and the mutation involved is PTCH in 9q22.3. I mentioned multiple of these. I would recommend you memorize it, but I highly doubt that they're going to ask about this. But if they're going to ask about genetics, they're mostly going to be asking you about the mutation itself. For basal cell carcinoma, it is PTCH. For melanoma and dysplastic nevus, it is CDKN2B, CDKN2A. You get the general gist of it. Hopefully, they don't ask you for SAQ on it. Your SAQs is, if I remember right, it will probably be on Pemphigus vulgaris or something like that, or something very simple, hopefully. But yeah, the CDKN2A mutation is dysplastic nevus or melanoma. PTCH is basal cell carcinoma, and squamous cell carcinoma is P53. Very straightforward, that one. Basal cell carcinoma, especially the NBCC or Gorlin syndrome, it follows the Knutson's two-hit hypothesis. I'll make this very simple for you guys. So people born with two alleles of PTCH, usually most genes come with two alleles. So, or all genes come up with two alleles. So yeah, they have two alleles of PTCH, and the people with the mutation, they have one mutated at birth. So this is hit number one. And the second mutation happens in the lifetime by UV light. You know, all the risk factors, like the risk factors are almost the same for almost all conditions. It's UV light, arsenic, blah, 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 all those, or even, yeah, mostly sun exposure. That is the biggest risk factor for sun exposure, UV light, vis-a-vis. So it is the biggest mutation for basal cell carcinoma. So they're born with the mutation, they're born with it, and then the second allele gets mutated because of sun exposure and whatnot. So when the two hits happen, it's over. That's where the cancer is formed. All right. So this is a very confusing slide on your lecture, but I'll try to keep it as simple as possible. I think I've got the hang of it. And this is the last slide, so great. Anyways, so we have PTCH that we discussed for basal cell carcinoma. It forms a complex with a gene called SMO, or smoothened. But imagine this as like a very stable family, you know, they're a couple, but it has a receptor for sonic hedgehog gene, which binds to PTCH, which results in release or the breakage of the complex between PTCH and SMO. So sonic here, or sonic hedgehog gene, is pretty much a homewrecker. It comes and destroys their family, and then SMO here takes advantage of the destroyed family, and they just, you know, while out. They go and they start activating gene expression, and this results in unregulated cell division and abnormal cell growth, which is basal cell carcinoma. So yeah, when SMO, or smoothened, is released by PTCH because of the binding with sonic hedgehog gene, that's where it pretty much activates the self-development cascade. And sonic hedgehog gene generally this is what it does everywhere. Like, it is a gene that where its goal is to promote more cell proliferation. So I don't know if you guys played Sonic as a kid, but you can imagine as, I don't know, this is Knuckles, PTCH is Knuckles, and SMO is the pink one, the girl one. They're a family. Sonic comes in, ruins their dynamic, and then once that happens, SMO is freed. And then, okay, I don't want to sound sexist. Let's just pretend this is Knuckles. Okay, Knuckles is the one who goes out to the street and goes crazy and results in cancer and basal cell carcinoma and whatnot. All right, so this is what happens in normal people, or like this is what what happens is that sonic hedgehog, when it binds, it results in this. But in NBCCS, or this condition, the mutated PTCH does not need sonic hedgehog to release SMO. So this relationship is doomed to begin with in patients with NBCCS. So this leaves SMO continuously activated, and when this mutation happens, SMO goes in and activates the cascade for cell expression. So there's unregulated cell division and abnormal growth, leading to basal cell carcinoma and abnormal patterns of cell growth. So hence cancer. I think that is the end of my presentation. I hope I covered as much, and there were a little few fumbles with the pictures and stuff. I hope you guys can forgive me for that. And, you know, I have a OSCE tomorrow, so I had to mix up between this presentation and my exam tomorrow, which has absolutely nothing to do with dermatology. So I hope this was productive. Hope this was useful. So anyone have any questions? Anyone online? Amazing. I hope this is beneficial. So if you have any questions, feel free to contact me. Here's my number. Here's my email. I'll send I think there was something I had to fix in this presentation, so I'm going to fix that. I'll add the pictures, and then I'll send this to the G&D people, and then they can share this presentation with you guys if you want to go through the questions again. And let me know if you have any doubts. You have my number here, and you have my email here. Yeah, it was a word thing. I'll fix it real quick and send it to you guys. So thank you so much. If no one has any questions, anyone have any questions? All good. Once again, thank you guys. Take care. Good luck on your exam. Inshallah, all goes well.